All right. So when I was asked to participate, we were given different topics. This is a topic that can be very perplexing to me as much as you, I'm sure. So I will try to work my way through my thought process, and when I see someone in the office who presents with some obvious asymmetries, either in the postures of their limb or in the posture of their pelvis. There's been a lot of discussion with Howard and Jenny about the pelvis and the low back, and certainly when there are asymmetries presenting, there are a myriad of reasons why that can be. Everything from muscle length to joint positions and static postures and strength. So I'll try to work through this a little bit. You could probably spend a good 3 days. Now the other thing, Terry mentioned this morning a story about an elite marathoner, so I have to share that story with you. It was actually someone who was sponsored to run. This gentleman was sponsored by a shoe company, and he had had recalcitrant Achilles problems for many, many years, and just had seen everyone in his area, which was about 5.5, 6 hours from where I live. So I agreed to take a look at this gentleman. He was referred by another physio in another state. And he had to drive about 5.5, 6 hours to get to the office, so we arranged to do it on a weekend. He actually stayed with Paula and I at our home, and then I went into the office and we took a look at him on Saturday morning. Well, this gentleman would finish a marathon under 2 hours and 10 minutes. So he would do a sub 5-minute mile for an entire marathon. So and when I was sort of getting a little bit of an idea of what his goals were, he intimated that. And I said, "Oh, that's amazing." He said, "Well, I thought you were a runner too." And I said, "Well, I am." And he said, "Well, I thought, have you run marathons?" I said, "Well, yes, I've completed a couple marathons." And he said, "Well, what was your time?" And my first response was daytime. It was still daytime. He said, "No, really, what was your time?" And I said, it was about 4 hours. And he said, "Oh my God, that's amazing." And I said, "No, it's not." He said, "Brian, I've never run for 4 hours." So it's all perspective. I am amazing in the perspective that I can run much longer than that guy. So that was my elite marathoner story. So we'll get into leg length inequality. And it has to be somewhat of this nature for us all to agree that there is one. So there are two main separations here I want to make. And there would be the structural leg length difference, which would be we are really talking about a difference in the long axis length of the segments, whether it be tibia, femur, within the calcaneus itself, any of those things. And then functional, which I have to deal with quite a bit, which are attributable more to the asymmetry in the joint position. But as I go through these, and we pick any one you want, pick excessive knee flexion on one side. That can either be the problem. Maybe they have an osteoarthritic knee, and that knee will not fully extend. And that now becomes their functional discrepancy. Or that could be their compensation, because maybe that's their longer leg, and that's how they achieve the level pelvis. So it's a bit of a double-edged sword with this. The functional may be a compensation for the structural. And therein lies my challenge in trying to make some sense of this. But I'll do what I can. And the other question is, how much of a difference is significant? I think we could pull everyone in the room. We might have as many opinions as there are people in the room. So I sort of went back through some of the literature, and these are some of the people that have made their opinions known. You heard the name Subotnick. So he was, again, big in running podiatry, running podiatric biomechanics. And he mentioned that, in his opinion, a 3 millimeter difference increased your risk of a running injury. 5 millimeters from Freiberg, he felt that this would lead to compensation in the spine. Then we go up to 6 millimeters from Brody, again, someone who dealt with running injuries mostly in the upper northwest in the United States, dealt a lot with a lot of elite level runners. Then 7 millimeters, Maitland and Corrigan basically said if it's less than 7 millimeters, really not so much of a problem. So the problems began somewhere around 7. Then we move up to 9 millimeters, and this showed some changes in lumbar facet angles when we got close to 1 centimeter. Getting to the next one, Syriac, which was actually one of my mentors long, long ago when I first started looking at soft tissue diagnosis and understanding various musculoskeletal problems, James Syriac was teaching in the United States, so I took a number of courses from James Syriac in the very early 80s. And then moving up a little bit more, compensatory scoliosis, again, now looking more at the proximal changes at 15 millimeters, 20 millimeters, now suggesting that we're going to see lower extremity compensation. Moving on up a little bit more, significant scoliosis when we get to 22 millimeters. And then 40 millimeters, which would obviously be a major difference, something that would even be an indicator for surgical correction. And this is sort of the zone where I hear things from my patients. They've often been seen by an orthopedic practitioner, and they have what's, to me, a fairly significant or an apparent structural difference. But in our discussions, it'll come out that, well, my doctor said if it's not an inch, it's not a problem. And I don't know if anyone's ever run across that. But I think they've seen a surgeon. And so I think what the surgeon is saying, it would not be a surgical indication for us to do any kind of osteotomy if you have a problem of less than an inch. But I don't think what they were really intimating is that if you have 3/4 of an inch, then you're going to be fine, and there won't be any lower extremity compensation. So it's sort of, you have to consider a little bit the source, and that's what I explained to the patient is, yes, I agree, you don't really need to have surgery for this. There are so many other things that we can do to try to get you a level set of lower extremities and a level pelvis by looking at your positions and things. So again, a little bit of difference of opinion there as far as what's significant. Now, in terms of the true structural length, there are clinical ways that we can look at this. Again, as a physio, I'm not typically ordering these things. You may be able to do that. Full-length AP radiographs, weight-bearing, and then the scanograms, either CT and also MRIs have been used for the scanograms, trying to look at the true vertical dimension of the limb. And what I'm looking at more is a clinical set of techniques. And so I'm going to be focusing on bony landmarks. So the landmarks that I'm going to be looking at are a lot up in the pelvis. So the iliac crest and looking at the heights there. The anterior superior iliac spine would be next. And then the posterior superior iliac spine, because again, within the pelvis itself, it doesn't simply have to be an upward shift or downward shift. There can be rotations of the innominate, and that can present now with changes in the acetabular position and present as a structural, or present as a leg length problem, which in fact is more of a functional discrepancy. So we'll look at that a little bit as we go. The knee joint line, again, this can tell us a little bit about tibial heights. I'll show you that on the clinical assessment technique. Looking at the malleoli, which is one of the typical ways I'll do it in the office, but sometimes difficult, particularly if the patient is rather large, if they're obese, or if they have a large genu valga. It makes it very difficult to put those malleoli next to each other so that you can actually make a good technique. And then also looking at the plantar foot contour, taking a look at the relative positions of the feet, although the plantar fat pad can be a bit problematic in that, and it's not always the same thickness on both sides. So again, these are the various positions that I'm looking at. So I would begin by looking non-weight bearing, doing a supine leg length assessment. So I typically will put the patient in hook lying, and then I have them try to set their pelvis relatively straight by having them bridge up and then gently let things down. And then I'll take a look at a couple things. I'll take a look at the heights here, and I may also swing around. If they don't have a particularly large knee, I may well be able to palpate the medial joint line of the tibia and see what the tibial heights look like in that position. And that will give me a little bit of an idea of how the tibia is sitting. Now, when we look at this position, you can see my fingertips on the anterior crest of the tibia, or the anterior part of the patellar tendon area, and that's to look at the relative length of the femur, but keeping in mind that that may reflect femoral length, but that may also reflect that innominate rotation that I mentioned. So we'll take a look at both of those things. So I assess both of those things. Also, be wearing the Osgood-Schlatter. Some people have a much more prominent tibial tuberosity because of changes at the apophysis during adolescence, so they may have a bit more prominent position there. And again, as we assess their tibial length, patellar height may not always be a accurate reflection. Jenny's videos of the patella moving all over the place. I was just so thankful that that patient lives in Australia. I have never seen a patella track like that in my life. So anyway. As we move to this, then I would gently extend the knees to take a look at the vertical dimension. Typically, if don't have a significant valgus, I'll go to the medial malleolus. Fairly easy to do if they have a genu vera or tibial vera. Not easy to go if they're obese or have a genu valga because the malleoli will be much further apart. Again, also typically I'm scanning down to the plantar heel to see where that sits. I then also will do a long sit test. And so when the patient is in supine, I'll get behind them, put my arm across their back, grab their arms across the front, because many of these patients don't have the best core stability, they don't have great abdominal strength. So as we move their pelvis, we have to make sure it's a clean movement. So I'll have them come to long sitting, and then I'll reassess. Now if that seems different, if you went from having a short right leg to now having relatively equal leg length, I'm going to go back and repeat that test again with particular attention to the landmarks. So we're going to take a look at where is that ASIS relative to the opposite. Is it higher? Is it lower? Where's the iliac crest relative to the other side? And typically also I'm going to have the patient then lie prone to see what position we see with regard to their PSIS. So changes in the long sit test can reflect significant rotations within the innominate. In general, this is the way you can think, that if we have an innominate that is posteriorly rotated, when they sit up, that innominate can rotate further forward. A posterior innominate will create an apparently short leg in supine. But when they sit up, the length of that limb will increase. An anterior innominate is already forward. It can go forward no further, so that side will not be the side that changes. So the relative position of the two, now which is hypomobile and which needs to be treated depends a little bit upon the movements. But in general, you can be thinking of if you have a short side that gets longer, then we want to check to see, do we have some kind of a rotation within the innominate? And that gets, again, to some of the treatments that we'll talk about. Now, there also have been many attempts to look at measuring leg length. A lot of different ways have been described. I've kind of listed them for you. The xiphoid to the medial malleolus. The umbilicus to the medial malleolus. We know in physical therapy school we learned this is apparent leg length. ASIS to medial malleolus, which has been the way that I've traditionally done this through the years, and bears out through most of the research as one of the better ways to do it. ASIS to lateral malleolus, again, not having to deal with changes around the thigh mass and the knee, sometimes make that a preferred technique for some clinicians. And then the greater trochanter to the lateral malleolus. The problem with that is on many of us, we can find that. On some others, you're not going to have the greatest luck finding the greater trochanter with any regularity. So that becomes a bit problematic. Now, there also are indirect ways to measure leg length, which would be palpating the iliac crest, trying to see are they sitting level, and then if we have pelvic obliquity, using a series of shims, typically 1/4 inch or about 6 millimeter shims, to see how much of a change does it take until we achieve a level pelvis. Now, realize that in these discussions, there's very little discussion about what's happening below the pelvis. In other words, are those knees in symmetrical flexion or extension? Are those subtalar joints in symmetrical pronation and supination? Are those hips in symmetrical ab and adduction? Just a little bit of abduction away from midline changes the relative position of the pelvis. But in the studies that have been done, they did show fairly good reliability with the full-length radiograph as far as the amount of correction that it takes to get to a level pelvis. When someone does have a true structural leg length difference, that is a fairly good way to get an approximation. So again, my typical way of measuring it clinically is from the ASIS to the medial malleolus. You typically do want to measure it twice. They've shown that validity-wise, if you measure once, not always the best thing to make a decision on. So if you see something, wait a moment, measure again, and then take those two measures together and to get your absolute there. Now, the other thing that I try to take a look at is what's happening within the rest of the limb. So being focused very much on the foot and seeing asymmetry in terms of foot function quite often in my practice, that's one of the first things that clues me that perhaps there is a leg length problem going on because I see more pronation or supination on one side. So I'll typically take their limb, internally rotate the limb to to cause their subtalar joint to pronate, externally rotate to bring it into supination, try to find their midpoint of congruency, and then take an assessment of that position. Now, I try to do this objectively. I use a little tool called an inclinometer. It's actually just a roofer's tool. They use it in carpentry to put the pitch of your roof together, so they have to be accurate. Otherwise, your roof wouldn't come together in the middle. So it's plus or minus less than a degree. And they have electronic ones and these simple gravity-driven ones. But it's very easy to put a number on this and fairly reliable between practitioners because I'm really only measuring one line as opposed to goniometry where we have to line something up with the tibia and something up with the calcaneus. So we'll check the resting attitude in neutral, and then I'll have the patient relax and see what is the change. Now, in relaxed position, it is not uncommon to see the heel move past vertical into what a lot of folks would call a calcaneal valgus. I tend to prefer to call that an everted calcaneus because it's not really a structural valgus that they're stuck in, it's a movement that they went into. So it's a movement into eversion as opposed to a neutral position valgus. So going backward, if I saw valgus in this position, that would be rather unusual. In fact, usually in my hands, that means I did a poor bisection of the calcaneus. So the amount of movement should be about 4 to 6 degrees into pronation and should be symmetrical. I should have relatively the same amount of motion on the two sides. So if one side is moving significantly more than the other, that may be another source of compensation. Now the other trick of that is I've also found over time that the better way to do that is not to do the neutral posture first, but to rather measure their relaxed posture first. Because when you put someone in a neutral subtalar position, or a more neutral congruent position, you've keyed them into it, and when you say relax, they don't. And so you don't see the same movement. So I prefer actually to get their relaxed position first, and then go ahead and change their posture and see how far that is from their relaxed position. It took a few years of very indiscriminate changes in my evaluation. I checked them one day and it would be 6 degrees, and the next day it would be 3 degrees, and that doesn't make any sense at all. So much better reliability in my own hands doing it that way. So again, this is subtalar excursion. And again, you can see here the neutral posture here, and then the relaxed posture. I don't know how much this is being washed out, but I think you can see that this side is going through a little bit more motion than the opposite side. The left, I think you'll see, is pronating a bit more. So it's just a neutral calcaneal position to the relaxed. 4 to 6 degrees is what I expect, and looking for asymmetry. Now I also will put them in a neutral posture of their foot and then look at the iliac crest heights. Look at those positions, the iliac crest, look at the PSIS, and then look at the ASIS. It may be that in neutral posture they have a very level pelvis. But when they relax, we see asymmetry because of the functional things going on below that. Or it may be the opposite, that they actually look fairly straight when they're in a relaxed posture. But when I put them in a more neutral posture of their foot, suddenly now we have an oblique pelvis. And that's going to help kind of drive, are we dealing with the structural or are we dealing with the functional? So we'll do relaxed iliac crest heights, check those same positions again, and then sort of see what has happened with that. Now, in terms of putting it all together, so the non-weight bearing assessment, the question is to ask, do we have symmetry in our pelvic girdle bony landmarks? Are the ASIS, PSIS, iliac crest, are they all in symmetrical position? What was their supine leg length, and did it change from supine to long sitting? And then, if we saw a difference, what was our tape measure assessment? Then moving to our stance posture, beginning with, do we have a level pelvis? Not stopping there, but beginning with that observation. If no, how much correction do we need to get to a level pelvis using our block test? Are the hips in a symmetrical position? Is one hip a bit more abducted, a little bit more flexed? If it's flexed, it usually is going to carry the knee with it. So hip and knee flexion tend to go together. So looking at those knees, are the knees symmetrical? Not just in the sagittal plane, but in the frontal plane. Are they in symmetrical varus and valgus? Because again, you tend to follow the path of least resistance. We're like electricity. If I have a long leg and I already have varus knees, it's a lot easier for me to just varus a little more on my long side. So we tend to go the way that we already want to go. So as I go through the compensations, that's my general rule. You're going to find that people tend to go the way that they're already going. Are their ankles symmetrical? Are they posturing with one foot a little bit more plantar flexed, or are they in dorsiflexion? Again, dorsiflexion of the ankle in a closed kinetic chain is going to be, again, linked typically with flexion of the knee, flexion of the hip. So that may be a total compensation for a structurally long leg. And then their subtalar excursion and their bony, the landmarks in their pelvis. So now kind of going through this, so if we have a level pelvis, that doesn't mean there's not a problem. So if we have asymmetry in their lower extremity position and their pelvis is okay, then correcting that lower extremity position may now throw their pelvis off. So this may be the person who comes in and we see that their right foot is significantly more pronated than their left. And so in all of my infinite wisdom, I decide to correct that. And because they're pronated more on the right, I put a 4-degree rear foot post and a 4-degree forefoot post to block some of the excessive motion that I saw on that side. What if that's their long leg? And the reason they were pronating the right side was to try to get the level pelvis. You can imagine how their back feels when they try to wear my foot orthosis, where I've corrected that. So again, you have to kind of put this all together. If, in fact, we did not see any asymmetries, then they may still require an orthotic device or a heel lift because they, I'm sorry, I said that backwards. If we had that situation where someone is pronating excessively on the long side, it doesn't mean I wouldn't put anything in their shoes for that problem. It just means I would tend to focus more on balancing the short side as opposed to posting up the side that's compensating. So again, that's sort of thinking through all of the things that go through there. Now, pelvic obliquity, I think too often when we see pelvic obliquity, we tend to rush to thinking that that's the person that has the structural leg length difference. And again, that may be completely a functional leg length difference. That may be that OA knee that has a flexion contracture. It may be that person who pronates the right subtalar joint more because their posterior tib is weak on that side. It may be their hip external rotators are weak. Well, if your hip external rotators are weak, as Jenny's explained, it's a total limb movement. So it's not just going to affect the rotation of the hip, but as the hip falls into internal rotation, it carries the knee into a functional valgus. That is going to shorten the limb. The internal rotation that is then accompanying that same position is carried down into the foot and produces excessive subtalar eversion and pronation. So just that simple problem may well reflect more of a functional leg length difference. So we're looking for the evidence of asymmetry all the way up and down. And so that's really what the rest of this is, just starting at the floor and working our way up. So for patterns of compensation, if we see increased subtalar pronation of the long limb, it's very, very common. That's typically going to be, for most people, their path of least resistance is to simply pronate more. So that if I have two legs that are of unequal length, it's much easier for me to simply pronate the long side. So it's a very, very common thing that I see in clinical practice. It also may be a very common source for poor orthotic tolerance, meaning that they don't like the correction because, in fact, that is their compensation. So they don't tolerate the device. They feel bad things in their hip or their knee or their back. Now, it is not a completely uncommon thing to see supination of the short limb. I tend to see this more on the more rigid foot type, the person who lacks subtalar eversion, or the forefoot valgus foot type, the more cavus foot with a plantar flex first ray. Again, their typical pattern of compensation is not into excessive rear foot pronation, but in fact may balance sometimes going the other direction. So for that, I will often see nothing happening on the long side, but rather a supination of the short side. And supination, of course, will lengthen your leg. So do we use an orthotic device or a heel lift? Well, if your pelvis is oblique and it appears short on the pronatory limb, then the orthotic support may be very appropriate. That would be the functional difference, where we have two normal structural length, but my right side, in fact, does go through excessive motion. So correcting that motion gives me a level pelvis. Orthotic's a good idea. If the pelvis is already level, correcting that asymmetry is a very bad idea, because that now leads me to the pelvic obliquity. In fact, the better thing to do in that situation is the use of a simple heel lift on the short side. And then that may take the load off of the subtalar joint that's pronating excessively. The ankle joint can also be a source of compensation. Typically, it takes some fairly large differences to see this compensation where you see plantar flexion of the ankle on the short side. It is something that you will see when the leg length difference is very large. This one is one that I see much more often, mostly because flexion contractures of the knee are not at all uncommon, so they're accompanied by ankle joint dorsiflexion. So I do see lots and lots of osteoarthritic knees. Most of them have flexion contractures as they move into the later stages of osteoarthritis, and they will often end up with more of a flexion contracture on their structurally long leg. Now the problem becomes also, I work a lot with orthopedic physical therapy too, people after a total knee. And so this can be a problem. I've actually created back pain before because the patient comes in, they present with a knee flexion contracture, and so not wanting to leave them there, I do all of my great therapy to get full knee extension, and now they have full knee extension on that side. But again, the other knee also has osteoarthritis and also has a knee flexion contracture. So as they notice their knee is much straighter, but their back doesn't feel so good. So again, you may have to do some compensations in the meantime to accommodate for the fact that that other knee, until it's been replaced, is not going to have the same ability to go into extension, so that we don't end up with pelvic obliquity. I still think it's the right thing to do, to give them a fully functioning knee, but we have to consider the vertical dimension of the limb as we do that. So again, the knee joint can certainly compensate in not just sagittal plane, but here we see frontal plane compensations, an increased knee valgus on this side. Again, this is someone who has lateral compartment osteoarthritis and is getting an increasing genu valgus on that side. And here we see the opposite, a little bit more varus on this side. So that can be a compensation. Now, there's been quite a bit of discussion in terms of varus and valgus in OA of the knee, so I'm going to get to that in just a second. This is what I was talking about with the flexion on one side and not the other. So this may equal out the pelvis, but certainly that can cause a lot of troubles at the knee. Now the other, not everyone goes that direction. Certainly in my younger clients, particularly the adolescent females that come in, many of the gymnasts, if they're in dance, ballet, many of them have hyperextension, so their compensation will often be to hyperextend their truly long side further. Now, in the orthopedic literature, and some of this actually came out of an area where I did my studies, which was Indianapolis, Indiana. There was an orthopedic surgeon there named Merrill Ritter who did a lot of studies on lateral heel wedges for medial osteoarthritis. And he showed that putting a lateral heel wedge, meaning putting the subtalar joint into pronation on someone who had medial osteoarthritis, would significantly decrease their pain levels, and it does. Because if you think about what we're doing when we're forcing pronation, that does increase that functional valgus. My problem is, what does that do to the foot over a long period of time? I think of the constant load that the posterior tibial tendon would be on while they're in there. I basically called the physician who's suggesting that I do this and say, is this person going to be a candidate for a knee reconstruction arthroplasty later? Because if they are, do you really want me to ruin their foot so that when you realign the limb proximally, now we have a foot that's completely been stretched out on the medial structures because of this forced pronation to sort of save the knee. It's sort of a valiant attempt to save a terminal knee in terms of the medial compartment. And there are other ways to do it. There are unloader braces, and they've shown that the unloader braces have just as much pain relief as the lateral wedge. There's an increased cost, but it's a much more direct way to put the load to try to push the knee into more of a valgus position by using sort of your three-point principle. And again, obviously saving the foot in this situation. So I'm not a big advocate of lateral heel wedges for medial knee osteoarthritis. Now the knee joint also is going to be functioning in the transverse plane, and this can certainly be a problem in that if someone has a long leg and they're posturing with knee flexion, that also produces a little bit of an internal rotation. This can be a source of troubles with anterior cruciate deficient knees. If you see an anterior cruciate deficient knee, they typically will develop an instability called ALRI, which is anterolateral rotary instability. Now you can do that yourself. They translate excessively anteriorly, but it's not straight. The lateral tibial plateau translates further than the medial. So if you think about what is that, particularly in the closed kinetic chain, that would be internal rotation of the tibia. And so you may well see someone posturing with a little more knee flexion, maybe even a little bit more pronation down in the foot because of a laxity in the limb, and that would also create some pelvic obliquity because that knee would posture initially rotated and perhaps a bit more pronated. I had a young man who was in my office. He was going to undergo a ligament reconstruction. And looking at his foot, he had a much more pronatory foot on that limb. And I said, I'm looking at your foot. I think maybe that may have had something to do with why you hurt your knee, because there's some association with rotations and ligament injuries. He says, no, I'm sure that's not the case. And I said, how do you know? And he said, well, because my foot wasn't like that before I hurt my knee. So I was thinking about the foot causing the knee injury, and he was reminding me that excessive translation in a rotatory plane at your knee changes your foot biomechanics. An interesting thing happened as his knee stability was restored in terms of his foot posture. Came back to a good posture. So it's, again, this total kinetic chain interaction that we sort of have to deal with here. Now, as I mentioned, the hip joint can also be a source of compensation here. In the frontal plane, if someone is posturing in a bit more abduction, that may level their pelvis. But if you put their feet directly underneath, that's when you see that hip go into a much more oblique position. I call this the party position because you'll find some people always, when they have the drink in their hand, they always kind of have that one hip out at one position. And invariably, if you're seeing them as a patient and they have a leg length difference, that's their long leg. Now, the pelvis problems, the upslips and rotations, these are things I deal with quite a bit. I do see a lot of runners in my practice. And running is a great way to create pelvic girdle asymmetry because you have the entire gait cycle is either single leg support or non-support. Never do you have both feet on the ground. And you have a magnification of forces of about 3. When you walk, it's about 1.2 times your body weight. When you run, it's about 3 times that, about 3 to 5 times your body weight. When you walk, your foot is on the ground for 0.6 of a second. When you run, your foot is on the ground for 0.2 of a second. So it's 3 times as much force, 3 times faster, because it has to be attenuated during that position, and all of that's going through a single limb, while the other limb, again, is swinging through space, producing the torque that we need to get going down the road. As Howard mentioned, the hip flexor is what drives the system. Well, all of that action going on around the innominates can create all kinds of little twists and torsions to the pelvic position. So an upslip would be where the entire pelvis has shifted upward. This may be, they may have missed a step, they may have simply had a hard impact and it sort of shoved the innominates straight upward. But what we would see, they would present as a short leg, but their ASIS would be higher on that side, and so would their PSIS be higher. So it's not a rotation, the entire hemipelvis is superior. So in looking at them, that's sort of what we would see. No change when we do the long sit test, because again, it's not an innominate rotation. Now there are corrections for these. This is a fairly simple one. This is much like the ankle distraction test that Howard was talking about when he was talking about treating the ankle. I typically would brace, get a little bit of a counterforce through my pelvis here, brace the opposite limb, then apply an intra-rotation moment at the femur to sort of lock the pelvis down, and then just apply a long axis distraction through the pelvis and try to get that pelvis to come back into a symmetrical position. And then again, after each of these, reassessing. Did we make a change? Now, an anterior innominate rotation would be a similar issue as far as the innominate is the problem. They would present as a longer leg because the innominate, as it rotates forward, is going to create an apparently long leg. What we would find is that their ASIS in the supine or standing position is lower on that side, but the PSIS would be higher. So I typically use my hands to explain to the patient, you're twisted a bit like this. And then in the long sitting position, that side typically cannot go further forward, so the other side would be the side that sort of goes forward and does not lengthen with the long sit test. Now to correct this, I'm going to use the muscles that attach through the pelvis. So I'm going to stabilize this limb. So this would be the side that I'm going to try to pull into a more posterior position. So we brace the opposite limb in hip extension, bring their involved hip up into flexion. Now they're going to use their hamstrings, which attach to the ischium, and now would create more of a posterior pull on that innominate. So we're going to have them typically would push down into my hands here, so they're pushing into me in a hip extension and also pulling down into my shoulder to try to produce a hamstring contraction while not allowing anything else to happen on the other side. And that creates a posterior rotation torque. And again, doing a few contractions in that manner and then reassessing, have we made a change? And quite often this will correct some of the innominate rotations that we see. The posterior innominate is just everything in reverse. Now this typically would present as a short leg. So this would appear short and supine, but when they long sit, it lengthens. Now it is certainly possible to have both a structural and a functional difference as far as your innominate positions. This could be a compensation for someone who has a truly structurally longer leg. So you may go from having equal length legs in supine to now that side being longer. So it's certainly possible for me to have both a structural and also a functional on the same leg. This may be a compensation for that. In other words, your work is not done once we fix the posterior innominate, if that's the case. So we take a look at that. The ASIS would be higher. The PSIS would be lower or more distal. And with the long sit test, that leg does get longer. Correction looks very similar. Now, instead of thinking about this side as the brace side, this is going to be the side we're actually trying to produce the torque. And we're going to use that rectus femoris, which anchors to the anterior and not part of the innominate, and try to pull that forward into more of an anterior rotation. Again, counter bracing with the upside leg. So bringing the other hip, actually I should say into flexion, not extension, and then stabilizing and having them flex their hip and extend their knee. So they're basically bracing against me here and then pushing up against my hand with that particular limb. You certainly don't have to have compensations below the innominate. This is where we do get pelvic obliquity. This can be the functional leg length difference. It can be all those asymmetries that we saw below. Or it may simply be that there are no compensations below. You have symmetry below the acetabulum, and that's their compensatory motion, and obviously they will tilt towards their structurally short side. When we do that, that's obviously when you're going to also see some significant changes in the lumbar spine, side tilting, and as we know about the lumbar spine and how the vertebral bodies rotate, that's not single plane. Typically, you're going to see triplane changes in the spine. Now, this can also become a bit of a chicken and egg thing. Is the problem that we have, quadratus contracture on one side or weakness on another side, and that's actually creating the pelvic obliquity. So at the end of this discussion, there's a whole other series of things you could look at from above. Is the scoliotic change part and parcel a result of my structural leg length difference, which I tend to think that that's a lot of the case, particularly in very early adolescence during growth spurts? Or is it the other way around, that we have a very asymmetrical spine and that's pulling the pelvis into an oblique position? So in summary, the lower extremity is going to be a dynamic kinetic chain. There's a lot of events, and obviously it can go in so many different directions with this. The patterns of compensatory motion, we have to ascertain, do they have a level pelvis? If they do, our work is not over. Then we look for asymmetry in the lower limb. Our treatment options can be everything from the lift correction to bracing the knee to correcting the pronation to the heel lift. So again, many, many different variations on this theme. So any questions about any and all of that? Yes? So if I just really repeat back question. So anatomically or structurally short leg and not see an oblique pelvis. Absolutely. And that would be, but what you would typically see is asymmetry in the limb function. We would tend to see something posturing, maybe a little less complete extension at heel strike, and let that knee perhaps being carried not quite into as much extension, and the other side functioning with a much better heel strike and going in and maintaining a more extended knee. And it doesn't have to be the knee, it could be in the foot. That you may see that as they go through the stance cycle on that right side, that foot tends to stay in excessive and prolonged pronation, but the pelvis still looks fine. They're keeping a nice level pelvis there. And that is that's the tough part of it, because the level pelvis is, so I remember as a young PT, my leg length examination consisted of checking your malleoli, if they looked okay, I stood you up. If your pelvis was level, I was done. And that was my leg length examination. I wasn't looking at asymmetries. I certainly wasn't looking, at rotations of the hemipelvis or upslips and all of those other things. That's why I think they say ignorance is bliss. If I felt, yes, my answer is yes, I would. This question is, would you treat that person, even though their pelvis is level? Would you consider treating them? I would, because we also said that they had asymmetry in their lower extremity function. So I would try it to see, did that initiate a change in how their lower extremity, their path of motion in the lower extremities? Now, if I didn't see that, and you have to be a bit careful with how much correction we introduce. I have my own little law that the body responds to small increments of change, but the body reacts to large increments of change. So I've done the right thing too fast and made people hurt quite a bit. So I've learned to just introduce change a little bit over time, and sometimes stop well short of what I thought it was going to take. And that's the bigger question is, let's say we measure a centimeter. Do we try to correct the full centimeter? I stop at the point where the function is looking better and the symptoms are controlled. So I typically don't correct the full unless that's what it takes to get them to that level. Good question. Any other questions? Yes? The popliteal fossa is a skin fold line. I think better if they don't have a knee effusion and they don't have a very hypertrophic infrapatellar fat pad. The medial joint line of the knee is a bit easier to palpate. Part of that's also that I do a lot of other treatments in my office, so I'm palpating knees all day long and pretty comfortable finding that medial joint line. But I like it better because it is a bony position. It's the medial tibial plateau. Fairly easy to find if you just go a little bit to the medial side of the infrapatellar tendon. Fairly easy to sort of find that plateau. But if not, it's certainly visually, it's an easy marker. It is typically going to reflect where that knee is bending. My only downside is it is on their skin, though. So, and skin moves not always with the bones. Okay? Very good. Thank you.